My name is Kendahl, and I will be presenting on rehabilitation following posterior semicircular canal occlusion surgery for a patient who had severe BPPV. This patient was seen initially February 6th and all the way through until February 14th, and I was in an inpatient rehab setting. So just to kind of preface my presentation, I just wanted to say that the Canal repositioning techniques and procedures are extremely effective. So the second year is what you've been learning will do great things. According to a FIFE article, the Canal repositioning procedures are established as an effective and safe therapy, and they should be offered to all patients of all ages who have posterior semicircular canal BPPV. This is considered a level A recommendation. Also, in my case, or the patient's case, she's extremely rare. Posterior semicircular canal, or the severity of symptoms that she experienced, she went through conservative treatment and it was ineffective for her. So kind of the last resort was the surgery that she went through. The surgery itself is posterior semicircular canal occlusion. There's another one called single neurectomy. What she chose was actually safer because it is, you have the chance of losing hearing if you have a single neurectomy, and the chance is lower when you do the posterior semicircular canal occlusion. So the purpose of my case was to really reflect on it and learn from this experience, and kind of to help improve my future patients and improve my skill set to help patients, as well as kind of get some insight from you guys as what you might do differently. And this is a general overview of the initial exam process. So went through a chart review, then it did subjective history. We'll go over a little bit of the surgical procedure and how that works. The initial examination, goals, evaluation, plan of care, and then just a summary slide. So for chart review, we get a pre-admit packet from the hospital and also like a health and physical from the medical director going through the patient. He does an evaluation and sends that over to physical therapy. So she's a 68-year-old female, and she has a past medical history of anxiety, breast cancer, arthritis, Sjogren's disease. I know it's Sjogren's disease because if you haven't heard of it, it is an immune disorder. It affects the mucous membranes of the eyes and the mouth primarily. So for her, it was just like a little bit of dry mouth. She had to sip water, and as I'll talk about, she also had bladder stretching. So the frequency that she had to go to the bathroom kind of is a safety concern for her. For the anxiety and stress kind of can be an exacerbation of BPPV's symptoms, or her dizziness symptoms, according to Morris. And so going further into the chart review, her family history includes dementia. She has a past surgical history of bladder stretching, which I mentioned. She lives in a one-story home with 4 steps to enter, and that's right-hand rail going up into the home. She lives alone. Her prior level of function was independent with all activities. Some of her hobbies include playing the guitar, reading, and dancing. Precautions following the surgery include keeping the incision dry, and that goes for occupational therapy mostly. The head of the bed was to remain at 30 degrees of an incline. She couldn't go farther back than that, and she was considered a fall risk at the time due to severity of symptoms going in, and then also post-operatively, we'll get there as well. Medications prior to surgery included lorazepam as needed, and this was for the anxiety. And she also was taking calcium and vitamin D supplements. So continuing on with subjective history, she started experiencing vertigo symptoms approximately 2 years ago. And then breaking it down from there, she described her symptoms in stages. So The first stage, she says, happens in May 2016. Oh, I'm sorry, backtrack. For the 2 years ago, she was repositioned by a ear, nose, and throat doctor. And she said that it worked somewhat, but it really didn't relieve all of her symptoms, and she ended up compensating by turning her whole body and head when she had to do movements. So she learned more of a compensatory type of thing versus solving the problem. So going back to stage 1, in May 2016, she describes her symptoms as spinning of the room. She woke up that morning on her right side in bed and said that she was experiencing the spinning. So she went to her primary care physician, who did a repositioning maneuver. When asked, what did he do exactly? She was just like, he rolled me, and that was pretty much the extent of her description. So from there on out, he referred her to an otolaryngologist, and when she went to go see him, he diagnosed her using what she said, the goggles. I'm assuming it's the frontal goggles, but he diagnosed her with right posterior semicircular canal BPPV. And so she then had her next episode in November 2016. So go from 2 years, and then May, and then 6 months, and then in December she experienced another episode. So now that's just 1 month in between. And then she started becoming treated every Friday for 3 weeks. It was ineffective for her, the repositioning techniques that they were utilizing. I can't say what they were exactly because that was not in the notes given at the time. Yeah.
She being treated still by the ENT, or she got a therapy?
The otolaryngologist that she was referred to, it wasn't the same ENT. Her primary care physician referred her to another one.
Okay, but it wasn't through a physical therapist, because I was in ENT's office.
Yes. Yes. So for subjective history continued, her second stage occurred in mid-January of 2017, and she describes her symptoms as rocking on a boat. This was a little bit of a change from the spinning. And so she ended up discussing with her doctor the next step of treatment. The repositioning techniques were not working for her. And what he told her was that all he could do for her at this point in time is we could do the posterior semicircular canal surgery. So he never really said anything about, there's vestibular rehabilitation, or had any knowledge of, the physical therapy aspect of things. So she went through with the surgery, and that was February 1st of 2017. And via the post-op report, she stated that she felt like she was spinning all the time. So then she comes to us on February 3rd. That was her initial evaluation date. And this she describes as her stage 3 of symptoms. And her symptoms included like the spring rocking horse, that toy, so going back and forth on that. Then I have going into the surgical procedure. I just kind of wanted to give you guys a little bit of a background of what she kind of went through. They do an incision along the mastoid process, and she did it on the right side. And what they do is they drill in until they can see the posterior semicircular canal, the bony aspect of it, and they kind of nick through that, pick at it, and then what they'll do is they make a mixture of basically the bone and some fascia, and then they occlude the area just like the picture shows right there, and then they close out and they do a cranioplasty. The success for these surgeries is by Shia. It said it was about 95%. 95% of the patients that had it at that time, they would do the surgery again. And then there was another study, can't click it too, that was done where I think it was 94 out of 97 patients said that they had complete relief of their BPP symptoms following the surgical procedure. However, all patients, via I think it's the Levick study, said that they experienced dizziness or vertigo symptoms following the procedure for either up to 3 weeks or a few weeks, 48 hours up to 3 weeks. So keep that in mind because that's kind of what my patient experienced for a little bit. So delving a little bit more into the initial exam, the patient, when I saw her, just looking at her, she was very tearful and anxious. We happened to come across her when nursing was in there and her case manager was in there, and then we were in there trying to do our physical or our examination, and it was a really overwhelming thing for the patient to experience. What I could gather from this at this point was that she was feeling nauseous and complaining of vomiting at times, and that what made her feel better was laying in bed, which she was doing. That's how we met. And then she said what made it worse was experiencing if she had hiccups, coughing, or sneezing, which I thought was interesting. And then the pain that she was experiencing postoperatively was, via the Groh analog scale, was 5 out of 10. And this was in the right temporal area as well as the incisional area, and she described it as a throbbing pain. The sensation that we tested was light touch and deep pressure and location, and this was intact. However, when we tried to go through the proprioception process, testing that, she was really unable to focus on us. She started, getting anxious and couldn't follow the directions. So we were really unable to accurately assess at that time. Strength was within functional limits because I'll get to the mobility grid, but you'll see from there. And then ocular motor, we weren't able to accurately assess at that time because of the severity of symptoms she was experiencing. So we saved that for a later date. Okay, so this is the mobility grid, also known as the CARE tool that we utilized at Health South. And as you can see at the top, that's more like the bed mobility that we kind of looked at. And she was generally, let's just say, she was supervision because she required cueing when going through the tasks, the sequencing of tasks so that she would follow her precautions and just kind of help her. She was struggling a little bit. As we get into more like the transitional movements, like to sit transfer, sit to stand, she needed mid assist, and that's with our hands-on kind of helping the patient up a little bit, just steadying because she was off balance going through those motions. And then, unfortunately, we were unable to assess the walking, the stairs, picking up an object. It was not safe for her at that time, and really the symptoms were a major factor. So then we have our functional independent measure score. What we thought she would be being discharged with was, at the time, a rolling walker. We were unable to assess the stairs, so we said that none, kind of thinking along the lines she might have to use a ramp going up into her house. If you recall, she had 4 stairs going in. Her bed chair, wheelchair functional status, that's an actual transfer from bed to chair to wheelchair, and she required mid assist with that for the steadying. And we utilized a stand pivot transfer. And that's just an example of, the ratings for the FINS score. So outcome measures. I utilized the dizziness handicap inventory. This has high test, retest reliability according to Jacobson and Newman. And she scored a 70 out of 100, which puts her in the category of a severe impairment. Also, Shia used this article specifically with people who have had posterior semicircular canal occlusion surgery and the application of PHI, which said that it was a good tool to use. I also used the ABC scale, activities specific balance confidence score, and she went through, and I don't know if you guys can really see, but there are 0s and 20s, and this was that she was 0% confident going to do these tasks. She had no confidence going through them. So on average, going through and dividing up, she had 15% confidence to perform these activities. So patient goals, keeping her in consideration, making it applicable to her. She stated that she would like to be able to go for a walk, enjoy life, just not to be afraid to go somewhere because of the vertigo. That was kind of sad, hard to hear. And then she also stated that I like to read. And then the physical therapy goals that we had set for her were bed mobility, transfers, ambulation, and this, just an overview was that we would put her at modified independent to perform these tasks, utilizing either a rolling walker or a handrail of the bed to perform. And then I also set an ocular motor goal for her, because even though I didn't get to assess it on the initial examination, I did it during her second visit, and I'll get to that. But I said the patient will be independent with gaze stability exercises in order to reduce vertigo symptoms, therefore increasing tolerance to transitional movements. So going over just assessing the patient and her impairments, she had impaired gait, balance deficits, coordination proprioception deficits, decreased activity tolerance, and then functional deficits, including transitional movements, transfers, and wheelchair mobility. I put that her primary impairments are ocular motor function and decreased activity tolerance. And I know decreased activity tolerance is general, but that was kind of including the fact that she wasn't doing very much prior to having the surgery. She wasn't leaving her house. She was unable to get around as well as she, once was independently. So those are what I consider the primary impairments. And then the plan of care ended up being an hour and a half a day for up to 2 weeks, and really working more so on the habituation exercises, balance, and then incorporating these into functional activities and the patient's hobbies. So dancing, walking, and transitional movements, such as dance. And this is kind of putting it through the HIAPEP or the ICF model that we learn about. So just to review, her health condition, she's status posterior semicircular canal occlusion surgery for severe BPPV, impairments, balance, decreased ocular motor function, activity tolerance, pain, activities, daily activities, change in positions, playing guitar, reading, and dancing. She is a mother, a homeowner, and a driver and dancer. She's environment is home and driving, and personal factors include that she's a 68-year-old female she does have lack of familial support. Her son didn't live in the area, and that was her only child. So, does anybody have any questions at this point? Go ahead.
You might be going over when you go over the ocular motor exam, but when she talked about her symptoms, was it just the rocking, first of all, like rocking horse, when you talk about her symptoms?
When she saw us, it was the toy rocking horse rocking. That's what she described it, compared to the bull rocking. So
she felt like you were moving versus she was moving?
No, she felt like she was moving. Yeah.
Okay. And did you note any nystagmus, spontaneous nystagmus?
No, not at this point. So the initial examination, or the day of initial examination, I didn't check like each test. I did that on the second day, which kind of goes into the intervention aspect.
But you didn't see anything spontaneous, like
no.
Nystagmus?
Not during examination. So when caring for the patient, utilizing the ICF model, making sure that the interventions are based on the impairments that the patient presents with, focusing on getting the function back for the patient and the patient's values, so considering her goals in our physical therapy program. Evidence-based physical therapy, that's what we do, and it's effective and efficient. So just going over the overview of the intervention, I'll address strengthening modalities, gait, ocular motor exercises, balance, and steer. So, like I said, the first couple of the days, she had a really hard time with the symptoms that she was having postoperatively. She was still having pain, and she had severe symptoms of the rocking horse. So we kind of stayed in a seated position for day one, and so one of the things that we addressed was strengthening on day one. She did seated wheelchair exercises, including the long arc quads and the marches, and we did 3 sets of 10 of those. It didn't affect her that much. She was able to tolerate those, but she said that she was tired afterwards and needed a rest break. Day 4, we did the new step at level 5 for 15 minutes, and this was really more so to incorporate the coordination aspect into things because she wasn't doing much prior to the surgery. So getting her up and getting those movements going again. Then there's gait. So on the first day of treatment, she actually walked 466 feet on a level surface, utilizing the rolling walker and min assist and a gait belt. And she did really, that's awesome. She wasn't even up on her first day, the initial evaluation. So the fact that she did 466 feet was great. However, she required frequent breaks throughout because the anxiety she started to experience, and she would get really frustrated. And so I ended up having to stop her. We kind of did a readjustment. She took 3 deep breaths, and then we would go forth and continue on, and she was able to do 466 feet. Day 2, we progressed 300 feet times 2. And she was more so on the supervision side, min assist just occasionally, and she continued to use the rolling walker and gait belt. Day 3, she was ready to go. She wanted to get outside. There was a therapy courtyard that we had, and she was able to walk around there twice. So it's roughly, I would say, 150 feet, but it was on unlevel or uneven surfaces, including grass, dirt, and cement. And she was able to adjust herself and be safe in each of those. And then by day 4, she was walking completely independent. She walked 30 feet, but she did have a decreased step and stride length, and she was able to perform 2 turns without any loss of balance. And on the 4th day, we ended up putting orders in for the patient so that she would be independent in her room. As I said before, she had to use the restroom frequently, so this allowed her to do so instead of calling nursing to kind of help her get there. And she also became modified independent throughout the facility, so she could go to her meals and everything like that without assistance. Well, minus the rolling water, but yeah. Modalities, we used a cervical cold pack, and this was only day 1 and day 2, and this was because of the pain that she was experiencing, mainly at the incision site. And she kind of did this at the end of her treatment with us, and she did 20 minutes, and we had her, and she had a high back wheelchair that declined backwards, and so she sat there and kind of relaxed and came down from the frustrations that she had through our therapy sessions. For the ocular motor exercises, what I did day 1 was I did do the H test on day 1 of treatment. I did the H test and looked at her convergence. And when I was going through the H test, I didn't notice any nystagmus, but she had a real difficult time going up into her right. She closed her eyes and she had to take a rest after we did that. And then after I did the H test again, just to see if that was kind of the same thing, I did a convergence coming in, and she got to about 12 inches outside of her face. And so then there was the onset of symptoms, and we had to take a rest from that again. So we just worked on, she just kept her head still, and we did saccades, horizontal and vertical, and then we also did, until the symptoms were provoked, so about 10 times each. And then progressing from there, for day 2, we did 12 times each, and then we did a focusing activity, more so, I guess it was convergence. She would look at an object close to her, and then she would look far, and coming back and forth, and that was done 12 times, and I consider back and forth once. We also did smooth pursuit. It wasn't VOR at this time, and I had her with a card, and she would just track with her eyes back and forth and up and down. Then by day 4, she progressed with the saccades 2 times 10, the focusing activity 2 times 10, and by day 5, she was doing 3 times 10, and I initiated the VOR. I ended up looking at that, and she was able to tolerate it, but after VOR 1, she took a rest break after the 20 times, and the VOR 2, 20 times. I used the rock string, which was really interesting because the occupational therapist had it, and she was like, what do you do with this? So I set it up, and we went through and basically did 2 sets of 5 laps of the rock string, and that fatigued the patient quite a bit, so we had to back down on the other focusing activity, which was only 2 sets of 5 that day. For balance, I addressed this day 3. Looking at her single leg stance, she was able to do 30 seconds times 2 on each leg without any loss of balance. And this was done on a level surface with her eyes open. Day 3 was also the day that we went out into the courtyard, and she was feeling very good. She was having a good day, and she wanted to practice her box step. And I said, I don't know what that is. And so therefore she ended up showing me, and she did that for 2 minutes. And I was like, well, this is great. We're putting it back into your hobbies. So then we did it again, and she felt really good, and we had to stop treatment. But day 6, then we continued on and looked at Romberg, single leg stance, and sharpened Romberg, and increased that to a minute each on flat surface. And then we did the Romberg and single leg stance on foam, 30 seconds each. She didn't have any loss of balance. Stair climbing, since she was going to have to go home and utilize those 4 stairs, because she was doing so well on day 3, we could do the stairs. She did 8 total on 6-inch steps using the left handrail and supervision. The patient noted to me, she was just like, I have to look at my feet. So I thought that was interesting. And then by day 6, she was able to perform 12 stairs using the handrail, and she wasn't looking at her feet. So that was pretty cool. So now the patient, because she progressed so well, she was ready to go. Her discharge date was February 14th. And so looking at the mobility grid from initial evaluation to discharge, she started with supervision to mid-assist and became independent with all of those activities, and then mod-I at the end because you're using a wheelchair, which is an assisted device. So she made some great gains there. For fins, she wasn't using any device, and her stairs device, she used the left handrail, so that's considered modified independent. And then with the transfer from bed chair and wheelchair, she was completely independent and yet again using the stand-to transfer. So this is the DHI and the ABC, the outcomes. So if you see over to your left, the DHI, she had a 70 out of 100% for her initial evaluation, and it actually went down to 8 out of 100. So that was a 62-point difference. And the MCID, I think, is 11 points. And according to another article, significant is 18 points. So she was well on her way, doing extremely well. Her ABC scale, her confidence went from an average of 15% to 86.25% confident in performing the tasks beforehand that she had 15%. So barriers to treatment, I would say that there was decreased communication between me and the occupational therapist at the time. She was doing a lot of exercises that we would do in physical therapy, and it would tire the patient out for our sessions, so we would only be able to do so much, and that kind of hindered my treatment. I'm going to put lack of research in the tissue healing guidelines together. When I was looking through, because the patient also had so many questions about the procedure, there wasn't much evidence or research at that time, and I was doing the best I could to provide her, but I had to guide her back to talking to her surgeon about some of the questions that she had because I wasn't sure. My limited clinical experience, I happened to be on, we're divided into teams at the inpatient rehab hospital, and I was on the team that worked primarily with CVAs. So this was the first time that I was dealing with a patient who had a vestibular issue. And then another barrier is the patient's anxiety during the treatments. It kind of really hindered our ability to go through more functional and thorough testing. Any questions? Go for it.
A couple things. First of all, can you describe a little bit more about kind of initially what her gait looked like as far as with her, when she was walking with the walker, and then what it actually looked like towards the end?
When she was using the walker, it was the unsteadiness, and she was still having the hiccups, as I was saying before, the hiccups and the burps, they would come on, and she would get so startled, and it would be very unsafe for her. We ended up having to follow her with a wheelchair when she first was walking because of the severe attacks that would come on. And so it was just unsteady kind of.
Did you do any head turning with her, or how much did she move her head, stuff like that?
With the walking?
Yeah.
I didn't do that at the end. That's maybe something I could have done.
Did you notice that when she was walking and you were talking to her, did she turn and look at different things and stuff
Well,
like that?
towards the end of her treatment with us, I would stand on either side. So like I would start out on her like left side, and then I'd switch over to the right at times, just talking to her. But I didn't know, it wasn't direct, like, you turn your head towards me this way.
Did you know, did she seem comfortable?
She was able to, yeah, she was definitely confident in her walking when at the end of her treatment, she was walking all around the facility. When I was with her, we walked around the facility and everything like that. And she had a lot of confidence. Go for it.
Do you think it would have been beneficial to do a DGI at dynamic gain index, like for the end especially?
Yeah, because I think of the function that she gained afterwards, I think it would have been,
Even starting, just to see.
Yeah.
To sort of tighten up the Dr. People's question, it would have been nice to sort of capture the combination.
yeah.
Can you repeat the question?
I think I would have utilized the DGI looking back on my treatment.
Can you elaborate as to your dosage with your oculomotor exercises as to why you picked the numbers that you did?
Because when she was doing them, it just happened that she was falling, her symptoms would come on after 10, and so then we would take a break at 10, or 12, or 2 seconds. So.